Hello, everyone. It's a great pleasure to be here with you. I would like to first thank Howard Wolinsky, Joe Gallo, Rick Davis, and James Schraidt for the invitation. In the next several minutes, we'll talk a little bit about how we can use prostate MRI to help patients with prostate cancer who are under active surveillance. So, very first thing, I have no relevant disclosures. And I think an important thing to start with is the definition of active surveillance and watchful waiting. Not uncommonly, I see these two terms being used interchangeably, but these are different approaches that are applied to different patients. Active surveillance is a management that actually has curative intent. Now, we use well-defined selection criteria to include patients in active surveillance, and we monitor very carefully for cancer progression. While watchful waiting is reserved to a much smaller number of patients, it's passive observations, typically used for patients with limited life expectancy due to other comorbidities. And the goal of watchful waiting is mostly palliative. So if we now look at a different definition, or it's the same definition, but in a different way, instead of a table, we look at what urologists usually say. So the aim of active surveillance is to maintain the opportunity of curing more aggressive disease via structured monitoring. So we use PSA and repeat prostate biopsies, which attempt to identify a change in the risk that this patient presents, usually by means of evaluating Gleason score. That would therefore merit definitive therapy. And why have we started doing active surveillance? Mostly because of two major issues. The first one is overdiagnosis. As PSA started being used to screen for prostate cancer, we started identifying many, many more patients who did indeed have prostate cancer, but prostate cancer was considered indolent and or incidental. So these are tumors that the patient will die with rather than of. And if we look at the number of cases worldwide, it's over 500,000 a year. Now, this also led to another issue, which is overtreatment. Now, it's very hard to tell a patient, sir, you have prostate cancer, let's not do anything. Let's just watch it. And it's hard to accept that. So many men will actually undergo definitive therapy for these indolent or incidental tumors. And that, of course, has impact on costs of healthcare, but also has an impact in patients as these treatments themselves are not indolent. No, patients have complications related to surgery and radiation therapy, for example. Now, a lot of has been written about active surveillance, and this is just for illustration purpose. I took 4 different studies here. And what these studies shows um, is that active surveillance can be used in several groups of patients. So in the first one, the study says that active surveillance is dominant at the age 65 or more. What does dominant mean? It basically says that in patients who are 65 or more, active surveillance tends to have better quality of life outcomes and tends to be a cheaper modality of management compared to more definitive treatments. And this is a cost-effective analysis. Similarly, the very lower one is a cost effectiveness analysis. In this one, the result was slightly different. Now, it shows that active surveillance may have a slightly lower prostate cancer specific survival, but that there were significant benefits in terms of quality of life. And the two studies in the middle, what they show is that when patients underwent surgery at a later time because they were under active surveillance, the results of the pathology were not different from the pathology results that was found in men that actually opted to go straight to surgery. So they compared people that went straight to surgery to those who had surgery at a later time point after active surveillance, and the pathology results were not different. I mentioned inclusion criteria before. What are the inclusion criteria? There are several out there, but as a general rule, what we're looking for are patients who have very low risk or low risk disease. And as I mentioned, there are several different protocols. I list three of them here, and what these show in common is that we're looking for localized disease, so disease that has not been extended outside the prostate. We're looking for patients that don't have a very high PSA, and we're looking for patients that have lower Gleason score. So typically less than 3+4 or Gleason 6. Now there are other criteria that are used depending on which group you look at, but this is the general approach. Now, what is a typical active surveillance protocol? So here's an example of patient A. Patient has a PSA drawn. The PSA was elevated, so the patient will undergo a transrectal ultrasound guided biopsy, which will diagnose prostate cancer, and then the patient will start active surveillance. So every 3 to 6 months, PSA will be drawn. If PSA remains flat, if it's stable, now, the patient may then later undergo another transrectal ultrasound guided biopsy at 12 to 24 months, every 12 to 36 months. So this is now a patient that is with stable PSA. Now, this is a different patient. In the beginning, things were very similar, PSA, biopsy diagnosis. But in this case, the follow-up PSA started rising. And because of this elevation in the serum PSA, this transrectal ultrasound guided biopsy was brought to an early time point. And in this particular example here, we see that biopsy identified upgrading of the disease, so a higher Gleason score, and then this patient goes to definitive therapy. What are the limitations of active surveillance? Now, there is nothing perfect in what we do, and active surveillance also has limitations. So the first thing is that a fairly large number of men will undergo definitive therapy within 2 years of starting active surveillance. And why is it that happens? In 75% of the cases, it's because of protocol-based recommendations. In other words, it's because upgrading was identified. And uh, a smaller number of men will actually opt to go to definitive therapy due to anxiety, for instance, because they cannot tolerate knowing that they have something that has been labeled cancer and not do anything about it. And not do anything is a perception, because in reality, active surveillance is doing something. We are monitoring actively. Why? Um, they do to definitive therapy then, because the rising PSA and detection of that upgrade. Now, if we look at the causes of that, it's typically because disease was mischaracterized at baseline. So the patient had actually higher grade disease at baseline, but he was not detected by the transrectal ultrasound guided biopsy. So limitations of transrectal ultrasound guided biopsy. Now, these images are courtesy of Yala Barons. I modified them a little bit. But here is an example. A patient has two lesions, two tumors. A larger one, it's more anterior, a smaller one, more posterior. The larger one has an area that has more aggressive disease within it. And when the biopsy is performed, the needle does not actually sample either of these two lesions, and we have a false negative result. This particular case doesn't really apply for active surveillance, because now if you don't find tumor, you don't really go into active surveillance. Now, here is an example where tumor was mischaracterized at baseline, and this can happen in two ways. One, we mischaracterized the Gleason score because we actually did not sample the more aggressive area. Instead, we sampled an area that was less aggressive, that have a lower Gleason score. And also, depending on the position of the needle, we may actually have a higher or lower volume of disease. So if you imagine that the needle tip, instead of being all the way here and then here, we would have just a little bit of the tumor, and we would underestimate its volume as well. And then the other reason for mischaracterizing tumor at baseline is because we sample a non-dominant tumor. So instead of sampling the large one and the area that is more aggressive, we actually identify a non-dominant indolent tumor and characterize the patient incorrectly. So to see better, what we need is our MRI glasses. So let's do a very simple comparison here. And on the top, I have a grayscale ultrasound image, and on the bottom, I have the prostate MRI, which has much better soft tissue resolution, and we can see things, quote, in color, quote. In reality, we're looking at grayscale too, but a wider range. So um, when we look at the ultrasound, you can say, well, I can see a subtle area. Actually, I can see the tumor there. But when you look at the MRI, things stand out. They're much more clearly identified. So let's look at an image of an ultrasound. Here is the tumor in the ultrasound. And a lot of you, while that I point to it, will say, well, no, it's pretty different from the rest of it. But I assure you that this is much easier to identify than that. Further, I can use other different sequences on MR. So instead of using that initial sequence, which was a T2-weighted image, I can actually use functional sequences, for example, the diffusion-weighted image. And now we can see that the contrast is markedly different, much easier to see that lesion. So these are our MRI glasses. Now, one of the things that we want to do, instead of targeting the tumor, instead of targeting the gland, we want to target the tumor. So imagine an ultrasound guided biopsy, a transrectal ultrasound guided biopsy. Imagine the earth here is now our gland, and we can just place needles on the gland and try to identify the areas of interest. But when we actually use MRI, we can actually identify that one particular area where we actually do want the needle to be. Now, this is a little video that I use when I moved to UW, but I think it illustrates exactly what we're trying to do. We're trying to pinpoint the area where we want the needle to be placed. So let me move this slide here. Because of all of that, now MR has really become a tool that has changed the way we practice. And instead of actually hearing this from a radiologist, now I rather have a quote from a urologist. And this is what Dr. Pokorny said. Now, MRI has now become the investigation of choice for all men with suspected prostate cancer. It has completely radicalized and changed our paradigm. So MR has indeed become a game changer. Now, we hear a lot, now, do you do multiparametric MRI, or what is your MR like? Is it multiparametric? So what is multiparametric MRI? Now, any MR study that we do, we acquire several different sequences. So in this particular example here, I have a T2 weighted image. I have a diffusion weighted image. These two here are contrast enhanced images. These are just ways to depict those images. This is MR spectroscopic imaging, and this is an ADC map, which is derived from this diffusion. So each one of these here are obtained with a different sequence. Each one of them show a different parameter. So we have 1, 2, 3, 4 parameters. So we have a multi-parametric MRI. Now we do this for all scans. If it's a liver scan, a pancreatic scan, they're always multi-parametric. Now the term became, is on vogue now because people talk about biparametric MRI. And the biparametric MRI is a protocol that acquired only these two and then the ADC map that's derived from it. All right, so at what time points in active surveillance we could use MRI? So one of the time points where we could do it is just after the patient has been diagnosed with cancer. And what we would do then is get an MRI to confirm candidacy now with targeted biopsy. So the patient has a PSA, had a biopsy, was diagnosed maybe with Gleason 3+3. He can get an MR, and then we will see if we identify a target and try to confirm candidacy with targeted biopsy. Now, what we're trying to avoid mischaracterization of disease at baseline. Because if we do see things that are much more suspicious, we can say you need to target that area, and then we will see if there's higher grade disease that will potentially make this patient not a adequate candidate for active surveillance. So first thing to remember is that a confirmatory biopsy is a very common practice prior to enrollment in active surveillance, and this is done all the time by urologists. Now, the second sentence talks about recommendation that's made following a negative biopsy if PSA continues to rise. So this is for diagnostic purpose. So you have a PSA, the PSA is maybe slightly elevated. Now a decision is made to do a transrectal ultrasound guided biopsy. The result comes back negative. Now the patient gets follow-up PSAs. The PSAs continue to rise. In that situation, an MR is recommended to identify a target that was missed. So if that's the case, why not use MR to confirm a diagnosis of low-grade prostate cancer? In particular, if you have a patient in which the clinical characteristics suggest he may have intermediate or high risk disease. It's the same logic. Now we have a tumor which is low grade, but something is not quite right. Let's get an MR to see if we missed something. So let's start talking about a little bit about that. And let's talk about negative MR. So if the MR is negative, here's an example where we have a T2 weighted image and a diffusion weighted image, and this is very, very normal looking. Now, several studies have looked at that. And the general result, the main information we should take out of this slide is that the patient that has a negative MR is unlikely to have clinically significant disease. That is disease that probably merits definitive therapy. Now, what is the negative predictive value? What does that mean? It means the probability that indeed there is no disease. So it's about 75 to 90%. Why is it ranging from 75 to 90%? It's ranging because the negative predictive value depends on how common prostate cancer is in that particular population. So if we are looking at MR in a group of patients that have a higher prevalence of disease at the time they get MR, the negative predictive value will be lower. If you're looking at a population where the prevalence of disease is lower at the time of MR, then we have a higher negative predictive value. Now, we have done other studies, we meaning radiologists and urologists. Our field has done more studies, and this is another one which a patient that had a negative MR was compared to a patient with a positive MR. There's a little finding right here. There's a T2 weighted images. It was shown that patients with positive MR had a 35% probability of having clinically significant disease on the confirmatory biopsy compared to 12% on the negative side. So the relative risk, so the difference between these is about 3 times. This is another study. This is another piece of information that is important, which is basically what I mentioned before. So the negative predictive value is not 100%. Now, and negative MR does not exclude clinically significant prostate cancer completely, but it certainly decreases the probability that one is present. We'll talk a little bit about that a little bit later on. Now, one of the things we can do to further stratify the risk of the patients is look at other things, not only at MR. And I always bring this point up because radiologists tend to focus a lot on the imaging side, but we have to remember that this is not the only tool that's available to our patients, and that in reality there are other things, and something very simple like PSA density will improve that risk stratification. So someone with a negative MR and a low PSA density is at even lower risk of having high-grade disease. Now, this is data from UCSF, and again, it's similar to the one I showed you before. We looked at negative MR and positive MR, and then at year 3 and 5, what proportion of those patients had a Gleason upgrade or not, right? So they were talking about free survival, so not having had the Gleason upgrade, but the idea is similar. So when you had a negative MR, people did not upgrade at 3 years at 92%. When they had a positive MR, only 53% did not upgrade. And at 5 years, the numbers were 84% and 35%. Now, this is treatment-free survival. So what proportion of patients did not have treatment at 3 years and 5 years in the negative group and in the positive group? So at 3 years, 87% of men with negative MR had not yet been treated, compared to 66% in the positive group. And at 5 years, 83% of men with negative MR had not yet been treated, compared to 54% of men who remained without treatment when they had a positive MR. So the question then is, can we skip the confirmatory biopsy if MRI is negative? But I think the answer is probably yes, especially if we take into account other variables. For example, I mentioned PSA density. But what if MRI is positive? Now, how will we deal with that? So let's look at some numbers and some results of studies that looked at positive MR. So one of the things that we see is that the tumor size also predicts the grade of the tumor. It seems to be logical, but now this has been shown now more objectively that larger prostate cancers are more likely to have a higher Gleason score than smaller prostate cancers. In this particular study, the threshold that was used to determine disproportions was 1 centimeter. So a tumor that was more than 1 centimeter was about twice more likely to be Gleason 7 or higher than a tumor that measured less than 1 centimeter. Now, another study looked at that same threshold, and when people had tumors that measure 1 centimeter or more, 80% of them were reclassified outside the active surveillance criteria. So this looked at different active surveillance criteria, but size of the lesion made 80% of those men ineligible to those protocols. Another thing that we can do is to look at tumor size to decide if the lesion is contained within the prostate or if it has expanded beyond the prostate. And again, larger tumors are more likely to be associated with extraprostatic extension, which makes a man ineligible to active surveillance. Another thing we can look at is how much contact this tumor has with the periphery of the gland. And when we see about 2 centimeters or more of that contact, so the extent of the contact is about 2 centimeters or more, patient is much more likely to have extraprostatic or extracapsular extension than if the tumor was smaller. An extracapsular extension, again, is an exclusion criteria for active surveillance. This is something slightly different. Now, this is a T2 weighted image. This is the ADC map of a diffusion weighted MR. And one of the things we can do is how much the tumor restricts, how dark it is. And the darker the tumor is on the ADC, so the lower the ADC value, the more likely this patient will have a higher Gleason score. So This is one of the studies that showed that tumors that had a ADC value of 0.84 or lower were more likely to have high Gleason score. This is a different type of study, but sort of the same lines as the one we showed before in the T2. Now we can measure ADC values to predict the outcome of men under active surveillance. And those men that have lower ADC values are more likely to fail active surveillance. Now we can do something slightly different. We can just look at our multiparametric MR and just count the number of sequences that are positive. So we have T2, we have diffusion, we have spectroscopy, and the greater the number of parameters, the greater the number of series that are positive, the more likely this patient will have upgrade on a confirmatory biopsy. Now, there are other things that we can do. We can assess the degree of suspicion on MRI. And the more suspicious we are on MR, the higher the probability that this patient will have high Gleason score disease. Now, there are different ways of doing this suspicion assessment. The most well-known is the PIRAD score, and we'll talk about that in more detail. But now when we use these scales and we go up in the scale of suspicion, now the results suggest that it is more likely the man will have high-grade disease. So scores 4 and 5, typically these are now a 5-point scale, are associated with both upgrading and therapy change. So if we do this at the baseline, at the time of confirmatory biopsy, we avoid waiting until this happens at a later time point. So MR targeted confirmatory biopsy is probably the ideal scenario in a patient that has a positive MR. Instead of doing a full systematic biopsy, perhaps we can do only that, but we'll talk more about that in a little bit. Now, another thing we can do too is to actually include the prostate MR, not at the early time point of active surveillance, but a later time point before the patient is scheduled to do a follow-up biopsy. So every 12 or more months, depending on the protocol. Now, if you think about that, there are 4 possible scenarios. We'll have a negative baseline MR. We're going to have a negative follow-up MR. We're going to have a negative baseline MR with a positive follow-up MR. Or we're going to have a positive baseline MR that has remained stable or perhaps even improved, or that positive MR that now shows more worrisome findings. Let's take now a peek at these here. So this is the same graph I showed you before, Gleason upgrade-free survival. This is the data that was obtained, but if we extrapolate the data over time, we can see that over the years, this is what we would expect. So if we look at this separation and the number of patients that have a negative MR that persist with without upgrade, now it's important to question ourselves now, should we actually just postpone the biopsy when that MR is negative? So instead of performing at that time point when the MR was done, should we postpone it another year or 2 years, depending on other risk factors? Now, if we look at the positive, the patient with the positive MR, we can see that there is a drop to all patients having upgraded at a certain time point. And if we see, therefore, a newly positive MR, it makes sense that we actually should an MR targeted biopsy of that particular lesion. So remember, these are patients, we're talking about patients that had a negative MR and that remains negative. Perhaps we should just postpone it. And then a patient that had a negative MR but now has a positive result in the follow-up, we should probably target that one area. So let's look at the patient that had positive MRs. One of the issues we have is that it's very difficult to predict which lesions will progress and when. So this is an example of a patient that had a baseline lesion that was fairly small. In the period of 6 years, that lesion grew but didn't grow markedly. And then between year 6 and 7, there was a marked difference in the appearance and size of this lesion. We don't really know why this happens here. And now remember, we want to maintain the, the, the curative intention of active surveillance. And now we still need to answer why this happens. But now what this illustrates that we can see the change from here to here. There's a big window of time where we can actually say, okay, now this is indeed growing. Let's target this lesion here. Let's see if there's upgrade, and then we avoid maybe getting to now a stage where the lesion is much bigger and may have potentially an impact on the patient's outcomes. Now let's look at something slightly different here. So these are two studies that were published fairly recent. And the arrow shows this name, Antonio Westphalen, which is me, and in both of them. In one of them, now the title reads, multiparametric MRI can exclude prostate cancer progression in patients on active surveillance. The other one says multiparametric MRI alone is insufficient to detect grade reclassification on active surveillance. So which one is right? So when we look at all these studies, it's important that we look into them with a little bit more detail. One of the major differences between these two studies is the way that progression was assessed in each one cohort. In the first one, the precise criteria was used. So it's prostate cancer, radiological estimation of change, and sequential evaluation. And what we see here is that a grade 1 is resolution of previous features. By grade 4 is significant increase in the size or conspicuity of the features that we're seeing. While in PIRADS, what we have is PIRADS 1 through 4 is an attempt to describe the probability of having high risk. So very low, low, intermediate, high, and very high. So what these two studies did, in spite of both using multiparametric MR, is look at the data that multiparametric MR provides in a different way. And that's why we get different results. So what's the message here? First is that there's no standardized image criteria to determine multiparametric MRI tumor progression, but it's something that's very important for us, and there are several groups evaluating that particular issue. Now, I want to point out that thinking that this is a linear scale from very low to low to mid to high risk, high to very high risk, is actually wishful thinking. And I'll show you some data. Now, that said, let's take a look at serial MR studies at UCSF. And now they looked at patients with low capillary risk, intermediate capillary risk, low Gleason score, and Gleason 3+4. This is the population that was included in this study. And what we found here is that a change from PIRADS score 1, 2, or 3 to a PIRADS score 4, 5 is indeed associated with upgrade and follow-up biopsy. So this bunch here, now, these people that had PIRADS 1, 2, or 3 on a follow-up had PIRADS 4 and 5. And these men actually did show higher grade disease in follow-up biopsy. So even though one of the studies showed that it's not sufficient, it actually does have an impact on some patients. Now, what is that this did? It actually basically said that there was a significant change in the score, in the appearance or in the size or conspicuity of a lesion, which corresponds to a precise category 4. All right, so now going back to that protocol, we looked at the baseline study, and we looked at the follow-up study, and we're trying to decide what to do. So if we have findings that are less conspicuous on the follow-up imaging, so that's a precise 2, or if the MR is unchanged, which is a precise 3, now we probably could postpone the biopsy or potentially offer targeted biopsy if there are other risk factors that suggest something is changing. Now, there is a target on both of that, so we could do a targeted biopsy. Now, if we have a precise 4 or 5, which means there is progression, then we definitely have to do targeted biopsy with MRI. All right, just a little teaser here. Not all PI-RADS score 4 are the same. This is an important thing to keep in mind, and that explains in part why changes in the PI-RADS scores are not necessarily something that is completely reliable. And just to show here different ways of reaching a PI-RADS score 4, this is for a tumor in the peripheral zone. If it's assigned a score 3 on diffusion, a score 4 on diffusion, the overall score will be dependent on potentially the DCE. And then lesions that are in the transition zone may also be assigned a score 4 in different ways. So just in these two tables, there are 5 different groups of patients and that have similar features, but now may get the same score or potentially score 3 or 4 in spite of other things being similar. Now, I want to go back again because I think it's a very important thing to keep in mind. MR imaging is not the only tool that we should use to make these assessments. And this is a study that we did, and we looked at the different PI-RADS scores, and we looked at the incorporation of PSA density to that assessment. And when we look at the PI-RADS score for lesions, when we use PSA density, now PSA density less than 0.15, those lesions behaved more like a PI-RADS 5 score. So again, MR is good, but we should not rely solely on it. Now, PSA density is something that's very easy, available to everyone, and should be considered in making these assessments. Now, let me take a little bit of a side tour here. We'll talk about complications of transrectal ultrasound guided biopsy. Many men will have prostatitis. Many of these will have infections that are resistant to common antibiotics. Some men will actually have hospitalization. And if you think about a transrectal ultrasound guided biopsy, we're talking about 12 to 16 core biopsies. And the question then is, can fewer core biopsies assess disease reliably? So in other words, do we need a systematic biopsy today? So remember, now today, when you do have a MR lesion that's visible and you can do an MR targeted biopsy that samples that particular finding, urologists will still do a systematic biopsy to assess the rest of the gland. And the reason is a negative MR does not completely exclude high-grade disease. Now, the question is, can we avoid that systematic component and do the targeted biopsy? So let's look at the study that was recently published by urology people from UCSF. Now, this looked at the characteristics of disease progression on serobiopsy. So they looked at the different biopsy results of men under active surveillance. And they looked at that with the intention of deciding if this man could undergo focal therapy. So this is an excerpt from the paper, except for a note that I added here and the underlinings. So findings of serobiopsies in men with low or intermediate risk disease on active surveillance show that the tumor location remains relatively stable over time, and that significant changes in grade and or volume occur largely in the dominant tumor. So what is the dominant tumor? Typically, that's the tumor that's visible on MRI. The combination of diagnostic and confirmatory biopsy findings better selects patients for focal therapy than the use of the diagnostic biopsy alone. So now having a confirmatory biopsy is important, and it can help to send patients to focal therapy. Now, this is also from their paper. Multiparametric MRI results were utilized to confirm the dominant tumor location after the diagnostic biopsy. In other words, the confirmatory biopsy was guided by MR. Given that multiparametric adoption is now widespread and most men have undergone multiparametric fusion biopsy at diagnosis, it may be feasible to offer focal therapy based on this information alone. So if we can offer focal therapy based on the multiparametric information, why not then just use that same rationale and use MR targeted biopsy alone on active surveillance? It seems to me that now that is a feasible approach when the follow-up biopsy, the follow-up MRI is positive. In particular, if the baseline was negative. Um, so here is another reason to actually do MR, doing an active surveillance. This is the patient in which the PSA is going up. So we suspect something is changing. We can, again, get an MR prior to biopsy to identify the target, and then we would do MR targeted biopsy. Now, another question that people ask, and this is coming from a group of urologists, is can MRI replace serial biopsies in men on active surveillance? And now this is the $64,000 question, and there are three major questions, not one. Each one of those needs to be answered the best we can to actually get there. So the first one is, what is clinically significant disease on MRI? And I think that we have some clue. It's the visibility, it's the conspicuity, and it's the size. What is progression on MRI? I think here we're doing pretty good too. We can use the precise categories. This is not yet fully assessed, but the studies are underway. And I think this will be how we will be able to determine progression of disease on MRI and maybe tweak to make it a little bit better. But we're in the right direction. Now, what is the significance of clinically significant prostate cancer that's diagnosed after negative MRI? That is the one that was not detected with MR, but was detected with the systematic biopsy. And we don't know for sure, but the impact of non-visible lesions, which are presumably small volume and at a high grade, is not presumed. It's unknown. We do not yet know what is the impact that that will have. However, there are outcomes data that are going on. Probably more will have to be done. Now, this is the one piece of the puzzle that's missing. But there is a lot of interest in that particular question. There is light in the end of the tunnel. This is from a medical record that I took quite a few years ago. This is 2015. And it says that the patient is doing well on active surveillance. It's been nearly 2 years since the last biopsy. We arranged for a transrectal ultrasound guided biopsy with MR prior. But if MR is normal, we might be able to follow him in the future, replacing biopsy with follow-up MR. Again, assuming that PSA remains stable. So this is in 2015. We can now think about that all the changes that happen over the years. This is a much more commonplace, although not yet widespread. Now, why all of this has happened? Because so many studies have been published. So these are slides that Dr. Padani now created and let me use. Very briefly, I want to talk about them. I'm not going to get into details, but this is the precision study that was published in the very prestigious New England Journal of Medicine. And what these studies did is they compare systematic biopsy with an MR pathway. And what this study shows is that when we actually use the MR to perform these biopsies, we avoid biopsy after a negative MR without impact. We detect more high-grade disease. We detect fewer of those indolent tumors that don't have a clinical impact, and we can do that with fewer core biopsies, so 4 cores per patient compared to 12, 16 of the systematic biopsy. This is called MRI first. It's another study. The results were very similar to, we can avoid biopsy in many patients with a negative MR. Again, we'll miss some, we know that. In this particular case here, there was no difference really in the number of significant tumors that were detected or not with one or the other modality. But again, fewer of the insignificant ones were detected when we did the MR, and again, with fewer core fewer specimens, so fewer samples in the biopsy. The 4M study, kind of similar to 49 men avoided negative biopsy, missing about 3 to 4% of clinically significant prostate cancer. Again, no difference in the rate of significant disease that was found doing systematic or doing the MR, fewer insignificant tumors, and again, fewer core. This is a meta-analysis, so this takes a lot of different studies and use statistical analysis to combine them and derive a summary number. And what this study found was that 33% of men would avoid biopsy, that would lower the detection of ISU group 1. So this is the grade group. This is the International Society of Urological Pathologists. They changed, they created this new grade groups to avoid the confusion that Gleason scores are associated with. This is a Gleason score 3+3. We increase the detection of group 2 or higher, so Gleason's 7 and higher using the MR pathway. And in particular, there was an increase in patients with Gleason 4+3 or more. So because of this data, thumbs up was given by many of the different societies and foundations and institutions. So this is the NICE, which is the UK Institute of Health and Care Excellence, the NCCN guidelines, the AUA, which is the Urological Association, radiation oncologists, oncologists, all recognize that MR does have a positive impact in the assessment of men with suspected and or known prostate cancer. Now let's talk a little bit about PIRADS. So this is a system that is used to evaluate the imaging findings on MRI. And the reason this was created is because in the mind of radiologists, we have this very organized idea. And then when we write a report, now that idea would arrive at the other side completely scrambled. And each radiologist would be using different scores, different brands of magnets, different strengths of magnet, different coils. And this created a lot of variation, which made very difficult to compare studies from different institutions and sometimes even from the same institution. So this was done to standardize. Even before, just a little bit before PIRADS was created, there was an European consensus meeting which suggested some criteria to actually come to a standardization of MR imaging. So in 2012, now this first paper was published, and this was the first time that PIRADS became a system, then the official PIRADS by the ACR in 2015, version 2, and then more recently, version 2.1. What is the goal of PIRADS? It's to improve detection, localization, characterization, and risk stratification in patients with suspected cancer in treatment-naive prostate cancer. It does not apply, for instance, to men who have been treated with radiation therapy, for example. And the way to think about it is as an ISO certificate. It's trying to standardize and maintain quality. So how reliable is PIRADS? And again, I'm going to go back to the levels of suspicion. And what are we trying to detect? So it's clinically significant cancer, which is a Gleason 7 or higher, that has a volume greater than 0.5 cc, or their astroprostatic extension. And there are 5 categories: very low, low, intermediate, high, and very high risk. And now this gives us the impression that this is a linear scale. This is utopia. That does not happen in real life. Again, that's wishful thinking. Now, this is the more real distribution of the probability of having cancer within each one of these categories. We can see that 1 and 2 are very similar. 3 is just a little bit higher, and then 4 and 5 go up more significantly. But there were studies showing this. So these are 2 studies. Actually, this is the result of 1 study. I'll show you the next one soon. This is a meta-analysis. We looked at several studies and we compiled those results. And so what we have here is the PIRADS. This is version 2. 1 or 2 were combined because this is basically a negative MR. 3, 4, and 5 were kept separate. We looked at Gleason score 3, 4, 4 plus 3 and greater than 8, 8 or greater. These are the percentage of patients within these groups and within these groups that had the disease. So 5.5%, the estimation has a margin of error, so it was 0.7 to 10% of the men that had a negative MR had Gleason 3 plus 4. Now, Gleason 4 plus 3 was 0.4, ranging from 0 to 1.4. Now, this number here is the estimation for any of these here. So when we compare any of these three here, so the higher Gleason score, the clinical significance, so 6.4% of men that had a negative MR had clinically significant prostate cancer. 11.5 for PIRADS score 3, 48 for PIRADS score 4, and 72 for PIRADS score 5. Now, one of the problems is, again, is the literature was highly heterogeneous, and that explains why we have very wide ranges now for each one of these categories here. So after that study, we did a bigger study, this from 26 centers in the US. And now we looked then at now what would we find, would we confirm those results or not? And pretty much we did. So here's PIRADS score version 2 again. These are the different scores, so 2 or higher, which is pretty much everyone, 3 or higher, 4 or higher, only 2, only 3, only 4, only 5. And this is the estimated probability of having clinically significant prostate cancer within that group. So now 5% of those with negative MR, 15% of those PIRADS 3, 40%, 39% with PIRADS 4, 72% of those with PIRADS 5. Now, just for comparison, these were the results of that meta-analysis. Now, a little bit different here for PIRADS 4, but overall very similar. So again, this is not a linear scale. The probability does not go 20%, 20%, 20%. In reality, it's much different. Now, these are the range that we found across the different institutions, the interquartile range. We can see that there's a lot of variability on that expectation of having cancer across institutions. Now, why does that happen? There are several reasons. One of them is because we, in spite of having something that looks as an objective tool, it is not. It's still subjective. It is not as objective as it seems to be. And now when you look at 6 experienced radiologists that read these cases, we still found that we would read those in a slightly different way, and then in some cases assign slightly different scores. Now, again, this is from Anwar Padani again, slides that he created. And this is a tweet that he placed and talking about the study that I wrote. So the positive predictive value of MRI directed biopsy. Now, is the radiologist, is it the surgeon, or is it the patient? We have to have a discussion. The reality, it's all of those. I think this slide is a little bit better here than this here. So let's look at that. And the summary of this is that we can't really look at PIRADS alone. It's not necessarily that PIRADS is inherently bad, but we need to look at the whole thing as a group. Now, there are many other factors in addition to PIRADS. So one, we have to actually have minimal technical standards. If a study is not done adequately, it should not be interpreted, or it should not be interpreted with the impression that you can be definitive. The MR quality needs to be good. The readers need to be experts and know what they're doing. Now, if I read an MR prostate and maybe someone who does usually mammographies read a MR prostate, we will definitely have different results. Obviously, I'm exaggerating here just to make a point, but reader expertise is important. Now, the suspicion threshold for biopsy is important because if we don't biopsy the same lesions at different institutions, our results will be impacted. So let's say in one place I biopsy everything that's 3, 4, and 5, and another place I biopsy only 4 or 5. Now the comparison of a positive MR will be impacted. Now, what biopsy method was used? Did we use fusion? Would you use systematic biopsy? Now, how good is the person performing the biopsy? And there is variation in histopathology as well. Histopathology is also a somewhat subjective assessment, and pathologists will disagree as well. In summary, what we need is a teamwork, and the best results are achieved in a place where that is happening within a group, not within not because of one radiologist, but because of a team that actually works now around and for those patients. PIRADS is a work in progress. Remember, we had version 2 and now have version 2.1. We will have additional versions as more data come up. Now, it's not perfect, but it's pretty good and getting better. And I think one of the most important things again to highlight is that multiparametric MRI is not PIRADS. PIRADS is one way to assess multiparametric MR. Another way, for instance, was to use the precise criteria. Now, it's also important to keep in mind that now we don't have healthcare resources distributed equally throughout the country. Now, in larger centers, you're going to have more radiologists, you're going to have more equipment, you're going to have more specialized radiologists than you will have in the rural area. And we have to think about that too when we say MR is the way you should do. Um, I'm not saying that patients in the rural areas should not have access to MR. I think we should actually work to improve access to those patients in a creative way. And maybe this pandemic is going to take us there. The other thing to keep in mind too is that MR is not an inexpensive tool. Now, very briefly, I want to mention future directions, and we'll start with molecular imaging. In particular, we're going to talk about PSMA, which was just recently approved by the FDA to assess for recurrent disease after treatment. So PSMA stands for prostate-specific membrane antigen, which is basically a protein that we have in our cells, normal cells, and prostate cancers and additional cancer, not only prostate cancer, but in prostate cancer cells, they're overexpressed. So if you look at this graph here, maybe we have 2 of these proteins in a normal cell, but in the prostate cancer, now it's riddled with it. And then what we do is we take an agent that shines now because it's loaded with radiation, and we give it to the patient. And that now agent will then bind to that protein. And when you look at this now using our PET scanners, we will see that the prostate cancer will shine more. It will have more uptake of these because it has more of those protein in the cells. Now, the agents we use is gallium PSMA 11. This is the one that was approved by the FDA, but there are other options. For instance, F18 agents can be used as well. So let me show you here an example, a 72-year-old gentleman with Gleason 4+4. We have a T2-weighted image. We have MR, diffusion-weighted image with ADC map. This is the PET in here. And this is a very large tumor. It's very easy to find this here on the T2 only. We don't need any of these other images here, but just to show you what they look like, right? This is very easy. And the point of this was not to actually detect that particular lesion, but to actually highlight the fact that that same patient has a lymph node that was fairly small. And I am not sure this lymph node would have been called by all the radiologists. Now, people that have read these a lot will probably identify this and make a mention of it on MR. But it's much more easily seen and much more easy to call it based on this uptake on the PSMA. Now, this is another example of a case in which we have a CT scan and we have the PAT, so it's a PAT CT with PSMA. This is just a PAT component. These are the two overlaid. They overlay these two. We can see a bone mat here, which is very visible. Now, radiologists will detect and will call this, but much more obviously now identified following the PSMA. And again, a very small lymph node is seen, much more difficult to identify it on the CT than on the overlay or on the PAT component. So now there is definitely use for that, in particular in patients that have high-grade disease, suspected radical prostatectomy in that case there. Now, this is a fantastic case. So these are scans that were done pretty close to each other, within days of each other. This is the CT scan. And you can maybe argue that you can see something here, but no, they'll be very, very difficult to call, if not impossible. Now, this is a bone scan, a bone scintigraphy. It's negative. We don't really see anything. And then here's the PSMA, where we can actually see 3 foci of uptake, which are very obvious. Again, it's a patient with radical prostatectomy with a high PSA, so he has a high risk for having recurrent or metastatic disease, and PSMA showed it very clearly. Now, one of the advantages of PSMA too is that it can actually show disease at very low PSA. So following radical prostatectomy, the level of PSA that we were looking at to suspect disease is above 0.2. And in this study here, we see that even in patients that had less than 0.2, 58% of them had positive scans. So it's a very sensitive method and very specific methods. It's really a game changer. Now, what about PSMA and active surveillance? So here's a study that looked at that, now trying to identify adverse pathology before surgery. And that's important. Remember, if we have adverse pathology, then we don't want to do active surveillance, right? And what we can see in this particular study is that there's a fair amount of overlap in the SUV. So what is SUV? This is how bright now the uptake is. So the higher the SUV, the more of that protein is capturing the PSMA. So the more positive it is, right? So now here we can see that there's a fair amount of overlap in the lower grade 3+4 with the 4+3 and 4+5. And the other thing too is that results may look better because we have these outliers here that actually change things. And the other limitation of this particular study is that there is no grade group 1, which is the Gleason 3+3, which is the group that we're mostly interested when we talk active surveillance. So again, that's the overlap in that particular group, the outliers. Now, this is another study again. Can we predict clinically significant prostate cancer? In this particular case here, we can see that the two graphs separate more. So the grade group 3, 4, and 5 separate from the grades 1 and 2. So the SUV is the uptake. Grade 1 and 2 have lower uptake than grades 3, 4, and 5. Now, the issue here is that because they didn't have enough of grade 1 and grade 2, they had to combine them to actually get some meaningful result. Grade 1 is Gleason 3+3, and grade 2 is Gleason 3+4. And not every man with Gleason 3+4 will be a candidate for active surveillance. And they may indeed have lower uptake, but we need to actually have larger studies to determine that. So what's the verdict for PSMA and active surveillance? Right now, the data is too scarce, too preliminary. We can't make any many conclusions. This is wrong. PSMA was just approved for the recurrent disease, but it should definitely be considered investigation in the setting of active surveillance. Micro ultrasound is another technique that is out there. I want to be clear, I have no personal experience with this, and the slides were given to me by a friend, Dr. Sanjit Ghai from Toronto. The advantage of this is that this is a system that urologists are used to. It basically looks the same. The main difference is that the system operates at a higher frequency, and the higher frequency, the greater the resolution you have. So you're going from a transducer that use 6 or 9 megahertz to 29 megahertz, which results in an improvement in 300% of the resolution, so down to 70 microns. Now, and he uses Primus categories to evaluate the findings. So here is an example. It's a little video showing a prostate. This is the seminal vesicle here at base. This is the apex on the bottom. And as you scroll through this, it's all this gray here, very confusing for people who have never really done this. So to make it simpler, let's take a look at that. So here we have one lesion that has the numbers. Here we have another one. Doesn't have the calibers on it, but the arrow points to it. This is the MR, and we can see those two lesions. Again, the anterior one, the more posterior one, and the more posterior one. So no, there's definitely some correlation between those two methods. We can identify the same things. So this was a study that actually looked at the micro ultrasound and MR. It's a large number of patients. It's a prospective study, 11 institutions in 7 countries. So this is not a bad study, but we'll talk a little bit about more in details. So a positive exam was a PIRATS 3 or more, or a Primus, so the ultrasound scale 3 or more. And they looked at the grade 2, so 3+4 or more. And what they found is that ultrasound is more sensitive and as specific as MR. Now, there are, again, this is promising, as I said, it's not a bad study, but there are limitations. First, the protocol varied from institution to institution. So a systematic biopsy was not always performed. The ultrasound was done after the MR, which probably helped the person doing the ultrasound to identify something that was seen on the MR, because they would look harder for it. Now, the borderline lesions, so the scores 3 on Primus and on PIRADS, were not necessarily biopsy. Some places did, and some places did not biopsy those. And the fusion method, or the use of any fusion method, also varied. So a few things to keep in mind. It is, again, promising result. I think we should look more into it, but there's no way to go. This comes from their own paper. There was substantial variation between sites. So it's not a radiologist necessarily saying this is the actual statement of the authors. They recognize that needs to be further evaluation. Now, just to show the numbers here, the top is the MR, the bottom is the ultrasound, and the numbers are not different. The positive predictive value, negative predictive value, a little bit lower for the MR. They did 2 types of study. They did a non-inferiority to say, okay, we do not see a difference, or we do see a difference. So when it's positive, so there was no difference. It's non-inferior. Basically, the method is non-inferior to MR. And this one here looks at the lower bottom part, looks at the difference. So what's the value of micro ultrasound? To be determined. We don't know yet. Now, in the end, I think we, as radiologists, have to keep in mind that behind each one of the images we're looking at, there is a patient. And I show this slide to all my trainees to remind them that although in this dark room, we are there for the patients, not for the computer monitors. Now, what are we looking for in the future? And we're working towards that. We're looking for something that's simple, for something that's fast, for something that's reproducible and accurate. And why not something that looks beautiful as well? So in short, now prostate MRI is not perfect, but it's a marked improvement compared to what we had before MRI. And it's an excellent addition to the active surveillance toolbox. Not the only tool, but it's one of the things that we should always consider. So with that, I would like to thank you for your attention. You have my email in the bottom. You have my Twitter name. And if you have any questions at any time, please feel free to reach out. Thank you.